Okay, today we have 4 speakers from 4 countries, representing 4 continents actually, and they have diverse background, but somehow related to public health and COVID-19 situation and response. So we are going to listen from them, and we'll have very interesting discussion toward the end of today's session. And I would like to welcome all of you and our speakers and our collaborators for this One Health Knowledge Cafe. As some of you might be joining this webinar for the first time, I'd like to briefly share about what One Health Knowledge Cafe is. So it is a collaborative effort of more than 11 individuals representing CIS partners and MLI. And we do represent Asia, Africa, Europe, South America, and North America. We bring together the expertise and network of researchers and professionals from various disciplines, countries, expertise to enable cross-learning, sharing, and network building. So this is just an example of what we can do, but we would like to know each other. We would like to learn from each other, and would like to build network for better health outcomes. So that's the aim of establishing this One Health Knowledge Cafe team. And as part of this program, we have planned monthly talk program, webinars, online courses, and discussions. And this initiative is supported by the Center for International Health at Ludwig Maximilian University in Munich, Germany, with generous support from German Academic Exchange Service, DAD, through their Exchange program. And it is funded by the BMJ, the Federal Ministry of Economic Cooperation of Germany. In today's presentation, we are going to listen from experts from 4 countries. And this map shows our current collaborators, location of current collaborators, and our aim to expand this further. And in today's program, we are going to listen from Brazil, from India, from Nicaragua, and from Tanzania. So our plan is to kind of get to learn from each other and to identify best practices or to share best practices to other countries or other locations. Very briefly, I'm not going to read out all of these, but this table shows the background information of the countries represented in today's program, and they're kind of diverse in different ways. So definitely in terms of the geographic location, they represent different continents, but also in terms of the population size. So we have a country with about 6.4 million to a country about 1.4 billion. So in terms of the size of population, in terms of the literacy rate of the population, in terms of per capita income of individuals, in terms of human resource for health, SRH density in those countries, it's quite diverse, and it's really interesting to learn from countries. Can you please unmute yourself? And
Hola. Todavía no desayuno, ¿verdad, Lucas? Todavía no desayuno.
Sorry. We have our first speaker, Russell Vicente, Dr. Russell Vicente, and she's a professor in the Department of Medicine and in the graduate program of infectious diseases. And she holds PhD in medical research from Center for International Health. So she's an alumnus of the Center for International Health, and she has experience in research on epidemiology of infectious diseases. So she's a perfect speaker for us. And Brazil is one of the countries with the highest number of cases. So it's really interesting to know how things are being handled, what are the things happening in Brazil. And similarly, we have our next speaker from India. and Dr. Jugal Kishore, who is a medical educator and a public health expert, who is currently the director and professor, as well as head of the community medicine in Surfdar Jung Hospital in India. And he has worked with different institutions and capacities. And you can learn more about Dr. Jugal in the website there. Our third speaker is from Nicaragua, so Dr. Aurora Argon, and she is currently independent consultant after serving the nation for a very long time. And she graduated as a medical practitioner and holds PhD in occupational medicine. She has worked in development of postgraduate programs in the field of occupational health, occupational medicine, and ergonomics. So we are going to learn more from her about the occupational health side of COVID-19. Our fourth speaker is from Tanzania. His Dr. Chambi Chachage is the 2018-2020 Princeton African Humanities Postdoctoral Research Associate. Is not directly from the health background, but it is going to be very interesting to learn from him based on his background and based on the different perspective. And as you can see from his bio here, he is focusing more on the African studies, history side of the discipline, and it's going to be a very interesting talk from Dr. Chachage as well. So the objective of this session is to share current situation of COVID-19, country responses and lessons learned across selected countries, to review and discuss key lessons learned for the global health community, and to establish a better network to promote learning and collaboration among CIS partners, alumni, but not limited to. So we are going to expand this beyond. So that's the purpose of this event. Just some housekeeping rules before I hand over this to our moderator. I would like to request all of you to keep yourself muted unless you are speaking. I would also like to keep your video off unless you are presenting, because sometimes this might help us with the bandwidth, especially if we are connecting from the slower internet connectivity. I would like to inform you that this session is being recorded, and the PowerPoint slides that our presenters have prepared will be shared later on in CIS website, which is www.cis.lmu.de. So you can get the PowerPoint slide and recording in that website. We have a Q&A session at the end of the presentation. So we encourage you to put your question in the chat box. And if there is any particular question to the particular presenter, just for clarification, we might take one or two for about 1 or 2 minutes, just for clarification, but the Q&A session will happen at the end, or at the second half of the program. And in case of any interruption, well, we may wait for 1 or 2 minutes for the presenter, and then we'll move on to our next phase of the program. So that this is the plan, or the housekeeping rules. Um, so I've taken about 5 minutes for this introduction. Now Sabina Sigdel, who is the moderator and the coordinator for this One Health Knowledge Cafe webinar, is going to facilitate next step. So we'll have 4 presentations from 4 country experts, and then we'll have a Q&A and discussion session towards the end of the program. So with this, I'd like to hand over this to Sabina.
Thank you, Deepak sir, for sharing all the information. There might be some background noise from me because it's raining very heavily here. So I'd like to welcome all the participants for taking the time to join today's webinar. So it's really great that we have an opportunity to hear from all the 4 country speakers, learn from their country experiences. So without any further delay, I'd like to welcome our first speakers. She is Dr. Rachel Vincent from Brazil. So over to you, Dr. Rachel.
Can you hear me?
Yes, loud and clear.
Okay.
Yes.
I'll share my presentation. So please say if it's okay. Can you see?
Yes, we can see it.
So thank you very much for the opportunity and the invitation to present the situation, responses and lessons learned in Brazil regarding COVID-19 pandemic. First of all, I would like to talk a little bit about the Brazilian health system. It's very important to understand our context. It was created in the Constitution of 1988, which states that health is a universal right and a duty of the state. It's organized as a unique system and decentralized, which means that the federal government, states and municipalities has concurrent responsibilities regarding the health decisions. This is one of the biggest health systems in the world, so it's universal. The population in Brazil is very huge, and also the territory is very large and diverse. It's super a lot with the pandemic, which started in the February. The first case confirmed in Brazil was in 26 February. It was a man who traveled to Italy and went to São Paulo. So in the first phase of the epidemic in Brazil, which is the beginning of March, what we have is many introductions, more than 100, of people traveling, especially from Europe, and coming to Brazil and in these cities of São Paulo and Rio de Janeiro. So in this first phase, we have these introductions, and then these people from these states went to another state, so it spread the disease to another metropolitan centers. Remember that Brazil is a very densely populated. In some areas, 80% of the population lives in less than 0.6% of the territory, and they are located, most of them, in the littoral area of Brazil. So now we reach the point to be the second country in the number of total cases, just behind United States. It's the number 9, then if we consider the relative incidence. So we have today more than 4 million cases of coronavirus in Brazil. The number of new reported cases in the last 24 hours is also very high, 40,000, more than 40,000. And also the recovered, more than 3 million. It's the country with more recorders of recovered patients. What we see here, the evolution of cases during the time, you don't see in Brazil a drop of the cases. It continues in the top 4 months. Also deaths, Brazil is a number 1 in the total, number 2 in the total deaths, only behind the United States with more than 100 deaths. It's a number 10 if we consider relative numbers. And also we have a high number of new deaths reported in the last 24 hours, more than 1,000. The fatality rate in Brazil is about 3%. Remember, we need to consider also underreport of deaths and also cases. But considering the confirmed, we have 3.1 fatality rate. The behavior is similar for the number of cases, so we don't have a drop in the cases along the time. Brazil maintains a high number. It's just a little difference along the time. And the cases are more concentrated in the littoral areas, in the capitals of the states, in the big cities, and also the deaths. But we have a tendency of reduction in many states, for example, 11 new cases and 17 new deaths. What we are observing in Brazil now is a reduction in the capitals and metropolitan areas, but an increase in the countryside. The response in Brazil started before the first case will be confirmed, considering also the international health regulations. So when we have the pneumonia of unknown cause confirmed by World Health Organization, Brazil asked for clarification, started to monitor the event, then started to publish the first informations, align the strategies. make the activation of alert level 1, level 2 when we have the first suspected case, and we will start to publish many bulletins talking about preventive measures considering the experience of other countries. So then we have the first case, and we started also with, for example, this ordinance regarding the quarantine, etc. So many laws and protocols to deal with COVID-19. So we have, for example, these 3 protocols. The first was the first one, the contingency plan. Then we have this clinical management in different settings. Here's the primary health care and guidance for the surveillance. Also, we have this program, Brasil Conta Comigo. It's like Brazil depends on me. It was created to training health professionals and register them. So all the health professionals who registered in their category were mandatory to make this course to know how to deal with COVID-19. Also, it permitted to contract more professionals, also with students in the last years of the university. Some states also constructed field hospitals, for example, São Paulo and Rio de Janeiro. In my state, Espírito Santo, it was not constructed, it's just try to reorganize the beds in the intensive care units, and it was quite good here. The molecular performance in the beginning of the epidemic was very hard because of we had this problem in entire world to buy the suppliers to do this. So, but it's increasing along the time. But it's not like a universal testing, etc. It's not for everyone. The beginning, especially, is more for people hospitalized or more severe cases. Regarding lockdown, so remember I said before that it's a responsibility of state, municipalities, and federal government to deal with health. But here in Brazil, we have a controversy regarding lockdown because our president was against this measure because of the economic issues. So the Supreme Court reinforced what the Constitution says, that also states and municipalities has responsibilities and can regulate this. So after this, some states and municipalities, here the number of the municipalities in these states who declare lockdown, so they were able to do this. The first was Maranhão state, and then it was quite okay. These places, they suffer a lot with problems in the health system. We have also, to reach this number, it was very confused, the response in Brazil, despite the beginning was very correct regarding considering the international health regulations. We had 3 health ministers in this period of pandemic. The first was fired in the beginning of April because he defended physical distance, but the president was against this measure, so he was fired. The second one was also a physician, but he resigned just 1 month before, because he was against also the president, because the president was defending use of chloroquine to the patients with COVID-19, so he just resigned. Since then, we have an interim minister. He is his CV in Portuguese, but if you can check, no experience in health area. So we also have changes with the communication, with this change of the minister. In the beginning, you can see, for example, number of deaths and cases. Then when we change the minister in the first time, so we start to put also number of recovered with more highlighting more this. And in the end of the August, still with this interim minister, Brazil is 3 million recovered people. No one worried about deaths and new cases. So it was a really fight in Brazil with media because the government starts to release, for example, the news about COVID-19 at 11, 10 p.m. So after the main broadcasts of the country, so the media also made an alternative way to publish this data before, collecting directly the departments, health departments in the states. And there was a point that this page just disappeared. We could not access in the federal government data. So the Supreme Court again obligated the federal government to release this data, but now when you enter, for example, in Ministry of Health Facebook, you need to enter to see all the data. It's not showed in the first screen. So this lack of transparency gives the impression for the person that in Brazil everything's okay, almost everyone has it covered, so it's very quite well. Another lesson we learned, this confused response was also because we need to take care of vulnerable population. If you analyze risk mortality in hospitalized patients with COVID-19, Pardo and Black had a higher risk, probably also because they have less access to the health services. Also, people living in favela, more than 13 million in Brazil. These areas are densely populated, sometimes with more than 3 people living in the same house and with the structure not so good or access to tap water, so very, very difficult to make preventions. Some of them just reorganize to try to respond alternatively to the state. Another problem is these people who live very far, for example, in Amazon area, who needs to travel along rivers, sometimes for days to reach services, which sometimes are not so well structured. And also it affects many tribes in the Amazon region. So indigenous population, we have a lot of cases and also deaths. Many communities in risk, more than 150. Affected, and we had another fight that Brazilian Supreme Court intervened because the federal government should have responsibility for this population and not just remain it to the states and municipalities, because the politics, health politics for the indigenous population is a little bit, it's more specific here in Brazil. So it calls our attention to the necessity to reinforce the international health regulation capacities in Brazil, especially related to health service provision and points of entry, which are below the average in the world. Also, we need to improve our Sistema Único de Saúde, our health service, especially with finance. Due to economic crisis, we are not able to increase investments in the Sistema Único de Saúde for more than 20 years. So imagine a country very huge with demographic transition and also epidemiological transition. And also to pay attention to intersectorial actions to approach inequities and social determinants of health. So it's very important. Here are some of the references, and thank you very much for your attention.
Thank you so much, Dr. Rachel, for your wonderful presentations and providing detailed information about the Brazil and sharing the COVID-19 experiences. So for the audiences, if you have any questions for Dr. Rachel, you can just type it in the chat box. Dr. Rachel will try to address it online. So with this, I would like to ask Dr. Jugal Kishore from India to present his presentations. We look forward to hearing from you, Dr. Jugal.
Thank you very much, Sabina. I want to share my screen.
Yeah.
Is seen?
Yeah, yes, we can see it.
Okay, fine. Thank you for this opportunity. You have prepared very well and coordinated very well. We are fighting against Corona for a very long period, and slowly we emerged out one of the largest contributor after US and Brazil. So the Brazil is here and India is here. So definitely what she has said about the Corona spread is similar to India, because the conditions are almost same. If we look at the slum area and some of the communities which are overpopulated, so the population is definitely a problem. So this one is already shared. I think what is important to see is that we have almost 2.6 crore, that is 26 million, more than 26 million people are there, and 0.8 million deaths. So that come out to be around less than 4%. And the recovery is also very good. But the active case is, if we look at it, then 99% are mild in nature, and only just 1% are actually critical and serious. And if we look at the close case, then definitely the death rate come out to be 4%. And most of the deaths are because of our older population, or those who are already have some um, comorbid condition which are there. So we can say that this is not as fatal as other disease which we have witnessed in past, uh, whether it is a corona or some other type of infection, but definitely much fatal than what we had in H1N1 infection. And we predicted that could be this H1N1 would be similar to the Spanish flu, but it proved to be wrong. But anyway, it was 100 years back this was happened, but a lot of things has changed. But what is not changed is the strategy, and that strategy is same as learning about the disease, and the preventive measures are same as we used to have in, maybe you can say 1300 or 1400, or maybe I think so. Those kind of strategies are still valid, uh, and all pharmaceuticals or whatever development we have is very less contributing even to total health. So that is what my focus would be. That we have to focus on those areas which are really neglected. Uh, this trend is already seen, and what is good that now the problem is almost stable, and the death is continuously same. It is not increasing, so that is a good sign. And the biggest peak, which was appeared to be yellow in color, that was due to the American region, is now going down. So the peak is already over. But what is worrisome was that blue color, which is still becoming larger. So this whole Southeast Asia region could be mainly contributing to the whole world, the number of cases. But I think that is also appeared to be stable. So we should not have any big issue as far as that spread of this condition is concerned. The most important learning is that over a period of time we are observing so many things. So what we are observing about the natural history of disease of this coronavirus, and we have learned many things. So through those all presentations and trends and graphs and mathematical modeling, we are learning that how we can understand the behavior of the virus and epidemic and pandemic both. Now this is quite interesting that the recovery and new case is now going side by side, and I think very soon we are not having more cases there as compared to the recovered case. So the pandemic is going to end soon. So these rates are indicating the good sign. Now what India has done, actually first case came in Kerala, and this the 3 student has came from the Wuhan, and in Wuhan itself, that when the pandemic was not started, it was highly battle at that place, and turmoil was there throughout that region. So from there, the patient, the people running from their home for survival or whatever it is. So the student has come to their home, but fortunately, what happened that Kerala promptly reacted, and all 3 cases were confined, and the disease doesn't spread from Kerala. So that is very good happened. But at the same time, in a very short period, the disease was there in Italy and then in Iran. So there is a religious functions in Iran. So many patients visited there and came to India. So then the infection start coming in Delhi and also in Mumbai, and then from Delhi, then various regions, because international flights come to these areas, and then these pilgrims and all people, they goes to different places from these international airports. So as soon as the patients keep coming to, or say the infected people keep coming, the screening at the airport started, and that was the only method by which we can limit. But that screening was not very rigorous, and that could be the reason that we have started very early, but that was not rigorous. That is why a lot of patients enter into the country, and we had the problem. So immediately the surveillance and outbreak investigation started, and we had the contact tracing, and very successfully we have all the people come from Wuhan, taken to one quarantine center in Delhi, very close to Delhi, and then we were able to contain that problem. And very good system, but definitely the import, or say incoming, was very high. The infection started because I think the infectivity was in the beginning was very high. So maybe because of that. So immediately the Epidemic Disease Act, which is very old in India, that was activated. And similarly, we have the Disaster Management Act. So when it reached to the disaster form, when it was there in various states, so the Disaster Management Act was also, activated for the, this pandemic, the disease. Otherwise, it is usually act on the other problem like the disasters, but it is appear to be the disease causing disaster. That is why this was immediately come into force. So what is started actually to be done is done by the government, but what is not done is actually the good risk communication. So the communication was gone in a very panic form, and a lot of hue and cry started because of the reporting throughout the country. And unfortunately, the involvement of the community was less. And immediately, the lockdown and all these things started. Community was forced to be in their home. So, there was a resentment, and things were totally, not into according to the, public health principles, where the community should have been equally responsible and part to the, control of the pandemic. So because of the two things, the things become much serious and severe. So whatever it is, then some kind of comparison is required at the national, international level. So the strategy which were applied by method like the testing and treatment and availability of the your hospitals and then ventilators, these all things gear up, and looking at it, how other countries are managing. So these all things happened, and then trend analysis was started. So you can compare between the two countries and within the country. But what was there in most of the places was a triage system, in which the red, yellow, and green phase were there. So even the area were, trials, and then we had the system of triaging of the patient and the hospitals. So 3 types of hospitals has been formed, and the isolation was made according to the, trial system. So that system was very well placed in India. But what is observed is the quality of care, and that was a big issue and big problem. Because of that, many of the patient or say the people do not want to go to the government settings, and the private bodies were not giving that much initially, that much help which should have been there. And the private sectors was also very much afraid and afraid, and many of the doctors were afraid. But in government settings, although the doctors were afraid, but they were, directly helping and also the treating the patients. Next issue was the handling of the dead bodies, which was also mismanaged many places. But in ultimately, when the guidelines came and it was circulated very well, so at each steps many guidelines came. That was good, but at the same time, maybe I think dissemination of those guidelines to each and every place, I think was not same. As in Brazil, we also have the system of that the state is the, responsible for health, and we are pioneer in that, because it was started in 1950s. But in the whole strategies, what is lacking was the mental health, and very late the mental health is also incorporated in total management of cases. So the mental health, the counseling, stress management, and dealing with the stigma was the major issue, because many cases emerged out where even the stigma against, or say discrimination against the healthcare workers, doctors was there in the community. So because of, again, mismanagement, myths, and all these things were there, which is quite common in such kind of pandemics. So what is this whole total strategy, control and preventive strategy is actually were in place, but some were in good quality, some in not. Some are, implemented well, some are not. So that is what whole strategy was there in India. The key interventions were actually response were that whatever should have been there should be sustainable. So some of the development which happened in many states actually just ad hoc arrangement. So development of the hospital in temporary basis may not be good. So if it would have been done in a more strong manner, I think these hospital, or say the settings, could have been used longer period. Then maybe I think the political leadership is definitely very important. So that would definitely going to help. But what is important is that if we can improve the scientific temperament of the people, it is going to help not only in pandemic but otherwise also. And democratic system should have been there, which was not in place. So the human values and these all things are very important, which were sidelined in many of the places. So what is the key intervention required is actually whatever development you are going to create in such kind of pandemic should not be just a short lived. It should have been, and total political leadership should realize the importance of the politics in health, make a long way to go. Similarly, this is the best time when people can realize that how scientific development is important, how we have to understand the whole science rather than myths and belief systems. That is what intervention would have been there. Now, what lessons are learned is that disease, infectious disease, doesn't respect the border, race, or religion, or even economic status and caste. So that is the most important part. Therefore, the investment on health is highly beneficial and it should be realized at the family level, at the community and national and international level. This is, I think, pandemic which is showing directly that yes, the investment is very, very important in health. And once again, it is focused that sanitation and hygiene is the only way of, helping you from majority of the problem which we face. And then in this pandemic, what we have learned that technology which is available now, this one, what we are doing now, this kind of webinar and all that, just because of the development of technology and it is used properly. And I think we should create such kind of technology which can make more, the population more empowered with the knowledge, the skills and all that. So that is what we have learned, that technology is going to help and should be used in that manner. But at the same time, the lifestyle which is required to be changed should be changed. So whatever in India, if you see that we are having big population which are, eating or say the chewing, tobacco, smoking, they are spitting here and there. The hygiene is totally, the respiratory etiquettes are very poor. So these are all cause of the spread of pandemic. So these are the lessons which I feel are learned from this pandemic. What is learned from the mathematical model? This has been published. That maybe I think the September end or middle of the September, but maybe I think the situation has a little changed. But maybe by the end of September or early of the October, we are going to, have the downtrend of the pandemic. So this mathematical model for the India is like this. The consideration is that, again, old principles that the action should have been at the local level, the state level and the international level. So that is what is known as a localized action for the global health or global action or global, well-being. So that is what need to be done. So a lot of interaction between people and states and the international bodies are required. And really, this is the time when people must come together, that even just one single virus can, destroy your everything. Your economy has gone down. Everything is now, in very bad shape. So in the end, just I want to raise this question: whatever development we are talking about today, which we have reached, is it the development or is it a sustainable development? Unfortunately, the total concept of development which we are seeing is that if we have more industry, we have more building, we have more car, if we have more home appliances and personal gadgets and more tourism, that is what development is. That is what the GDP and economy is. But this is all wrong. I think we have a wrong concept of development. So this is very best time to redefine all your concepts of the living and life. So with these words, I just want to say thank you for giving me this opportunity. Thank you very much.
Many thanks, Dr. Jugal, for all your elaborative and very analytical presentations. So with this, we'd like to move on to our next presentations. I'd like to welcome Dr. Aurora Argon from Nicaragua to share her presentations. Welcome, Dr. Argon.
I'm gonna share my screen. Here it is. Do you see it?
Yes, we can see. Yeah.
Thanks a lot. Thank you very much for this invitation. I'm going to share what the situation is with Nicaragua. I think it's a bit different from other countries in the sense that the reaction of our government was very contrary to what people would expect with a pandemic like this, COVID-19. COVID-19 appeared in Nicaragua in a context of, in the middle of a political crisis of 2 years, with population resistance from April 2018, where there have been human rights violations, hundreds of people dead during protests, imprisonment of more than 1,000 protesters, mostly youth people with false accusations. The whole situation has affected the economy of the country and had visible consequences in terms of increased poverty and huge migration, as well as the international isolation of the government and a wave of repression that still continues. In the beginning of March 2020, the government reacted to the pandemic with this unexpected wave. You see the pictures. The first pictures on the left says love in times of COVID. Like we were welcoming COVID as it was a good thing. Contrary to the rest of the country, instead of following the World Health Organization recommendations, Nicaraguan government organized several and thousands of mass activities to welcome COVID. It took more than 2 months for the government to accept that community spread was in place. When we had the first case, these few cases were kept for several days, and they kept saying that they were imported, but to give you an idea of how the situation was, Cuba has reported a number of cases imported from Nicaragua, and we were denying that we had community cases in the community. In the same period, some people reported a new type of respiratory symptoms with slow recovery, not compared with the typical pneumonia or influenza, no diagnosis, not diagnosed as COVID, and not even tested, lab tested. Private medical doctors have also informally reported to start seeing COVID cases as soon as March, while officially we were just having the very first case. That was someone who travels to the south of Nicaragua, and they said that there was no more cases in the community and everything was under control. Parallel to that, the Ministry of Health internally, they were taking steps for preparation with the pandemic. They make their calculations of how many people will get the disease and how many will die. And also they implemented a sort of direct phone line that basically was when someone having symptoms was calling, they basically recommended to visit the primary healthcare units to get attended. However, those with the suspected symptoms were not offered any lab testing. But diagnosed and treated as a common, not related to COVID, respiratory disease or another disease. And what concerns the measures to be taken to prevent the disease, there were recommendations, but instead of using the mass media or they were visiting houses, and the health personnel that calls the attention of the population that the health workers were not protected where they were doing the visits. Additionally, as late as June, Nicaragua didn't show any sign of providing any income support. If we see in this picture also, the map of where Nicaragua, it's in red, showing that there was no income support from the government to those who were not working or were unemployed, since the country was we've been having this economic crisis, and the government said that they cannot support this economically this population. Here we have the numbers, the figures of COVID-19 situation, and this is something that I need to explain to you. In the left side, up in the left side, is the beginning of the cases. Since there were rumors that there were more cases than the Ministry of Health was reporting, and in the independent media interviews reflected that may have been more cases, a group of epidemiologists decided to establish a parallel surveillance system with self-reported cases recruited through a network of health personnel, private doctors, and those people who were ill that were informing about their symptoms, treatment taken, and clinical diagnosis of the disease. This newly installed surveillance system called Observatorio Ciudadano in Spanish, Citizens Observatory. If we look at this slide up in the left, while the Ministry of Health was reporting just 2 cases, the Citizens Observatory reported 47. As concerned with in relation to death, Ministry of Health only acknowledged to have 5.5% of those reported by the observatory. On the right side, we have the figures that the observatory have been reporting, and down we have the figures of number of cases, and here up is the number of deaths. So you could see that there is more than 2,000 reported by the observatory, but only 140 reported by the Ministry of Health. Very, very, very few cases. During the late August, the database of tested cases at the lab, at the national lab of the Ministry of Health, was subtracted and sent to the media. This database was analyzed by a Nicaraguan epidemiologist located in the United Kingdom. And if we see the figure, the first week that Minsa reported 1 case, there were 7 cases already tested by the same ministry, by the lab of the same ministry, but not declared. If you see the figure, there are huge differences between those reported by officially and those that were tested positive by the lab, by the national lab. If we, from this data set, we could see that they have tested 17,000, 56% were positive, and only 35% were officially acknowledged by the Ministry of Health. When compared the data between the observatory, the number of cases that tested positive is similar to the ones that the observatory has been reporting. We think that this is not the total number of cases, that we are just seeing the tip of the iceberg, but it calls the attention that there are similarities of what the self-report and the network information were given concerning the number of cases in the country. According to this graph, fatality rate is 1.4% based on the number of the Ministry of Health. But if you that is 140 cases. But when you see and you read the newspapers and you see the reports of associations, national associations of people that have died, like for instance, medical association, they have reported the 104 health personnel that have died during this pandemic, and 700, almost 800 have got ill during the pandemic. The Lawyers Association, they have reported 50 deaths. And the Public Accountants Association, they have reported 15. The Teachers Association, they have reported around 40 deaths. This will sum up more than 200. And if you compare with the number that is being declared for the whole country. So it's impossible to match these calculations. If I think in my own neighborhood, we have had 3 people who have died: a psychologist, a dressmaker, and a retired person. None of them is from the list of those that medical association, for instance, have been reported, or the other occupations. So it gives you the idea of how the situation was or has been. As I used to say, we are sort of living in 2 parallel worlds. People decide what to believe, and it will strongly depends on where they are positioned. If they work at the government or they are affiliated to the political party of the government, they will listen to what government says, even though they know that they are not true figures. Summarizing the responses of the government from the beginning to today, there were no restrictions, no lockdown. Masks at the beginning were forbidden among health personnel. They were promoting all the time mass activities. Governmental institutions, public schools, and public universities were forced to stay open. Primary healthcare personnel visited houses and communities without protection, just by asking if there was any sick person and just providing recommendations. Government media misinformed the population not to be afraid of the virus. They say that with influenza, some said that with influenza vaccines were protected, or that our population was strong enough to resist the viral infection, insinuating that only rich people could be affected. And they also compared with Ebola, that was something crazy. Lab tests, RT-PCR, were not available for hospitals and private services, but only Ministry of Health. Death certificates of symptomatic cases, COVID cases, were officially declared as community pneumonia, unrelated to COVID, or if it was declared as COVID cases, they usually mention that it was because of comorbidities, diabetes, hypertension, etc. Until now, the government institutions has not stopped their work. Those people that got ill have been permitted to stay at home without being tested or officially diagnosed. Not all of them appear in the statistics. They seem to choose the cases, but this is what the government has done. But the citizenship, private companies, and social organizations, they have done their own. And one of the things was the creation of a multidisciplinary scientific committee that aimed at education, providing information through the popular medias like Facebook, Twitter, YouTube. There was also Nicaragua Medical Union that were offering the medical attention via online. And the Citizen Observatory COVID-19 was created. The Catholic Church and civil organizations were organized themselves to collect money or donations to provide personal protective equipment for health personnel. And in some areas, where vulnerable population are, there were a sort of solidarity chains in neighborhood or online. Example, the journalists, the newspaper or media, independent journalists that were ill, they were supported, providing money or medicines to treat the disease. The 34 medical associations called in June, at the beginning of June, because of the increase of the cases and the increase of death. Hospitals were crowded. They called for voluntary quarantine if it was possible. There were groups distributing cleaning kits and masks in popular markets and disadvantaged communities. As the disease progressed and news of several deaths due to COVID-19 were spread along the communities, parents voluntarily decided not to send their children to schools, and elderly people stayed at home. In parallel, private clinics and labs were also crowded with people looking for clinical diagnosis and medical prescriptions, and pharmacies were selling these medicines without prescription. This figure shows the news from national news papers that are digital newspapers like Confidencial, where they are informing that the medical associations in Nicaragua call for a 4-week voluntary quarantine. There were more than 700 doctors, medical doctors that signed this call, and some of them belong to the Ministry of Health. Those that were working at the Ministry of Health were fired by the Ministry of Health, saying that they were alarming the population and giving false information. And the other news, it says that the 104 health workers and 45 teachers have died due to COVID-19 in the country, and this was reported in August 16. As time went by, and with the government officials seriously ill, there were several of them that have died. A growing number of officials began to use protection in public health. Before they didn't wear any masks, they didn't keep distance, etc. With hospitals crowded with severely ill patients and reduced health personnel, some ill, some died. Means of protection have been allowed. Mass activities have been reduced, stimulated mainly by local leaders' decision or by not participation of the population, but not by the high level of the country. The large informal sector, those underemployed, never stopped working, but now it's more frequent to see them wearing masks and carrying alcohol with them and washing their hands, or having a sort of improvised place where they can wash their hands. Supermarkets, government institutions, public restaurants and services are now measuring temperature of those who get in there and provide alcohol to clean the hands of customers. Nowadays, as the pandemic goes, population has become to be relaxed. This is something that worries us. mass activities continue to be stimulated by the government. There were recently a baseball match, and it was crowded. Due to severe criticism at the end of May, the government presented their own report of how they see they've been taking care of the pandemic and their strategies. They responded, and they say that their strategy responds to the need to keep the balance of the economic impact with the pandemic impact. Although not officially informed, pro-government media and government officials have argued that Nicaragua decide for herd immunity, comparing their decision with what Sweden has done. And the reporting and the registration of cases and death do not allow to understand the real impacts of the pandemic in Nicaragua. We think that we just have seen and registered and reported the tip of the iceberg. Even though the Ministry of Health has been made lab testing, there was a sort of orientation to health workers. If the person has clear signs of COVID, they were to be treated, but not to be tested. And they shouldn't be reported as COVID. Okay, that was all with my presentation. If you have any question, you are welcome.
Thank you, Dr. Arora, for your informative delivery. So without any further delay, I would like to call upon Dr. Chambi Chikaji for his presentations. So I also would like to remind you that presentation will be of 10 minutes. So over to you, Dr. Chambi. Thank you. Dr. Chambi, can you hear me?
Can you allow me to share my screen, please?
So I think Aurora need to stop sharing your screen first, and then you can share your screen.
Okay. Wait a second. Right. Oh my. Here it is.
So you can see a green color with the comments. So you can use the option there to stop your screen. Yeah. At the top of the screen, you can see the options there to stop your screen.
I think I have done it, but I don't see the changes.
So she has to close her screen, like on the red, that red, like the red X.
Okay. Is it okay now?
It's still there.
Okay. Now.
Okay. Welcome, Dr. Chambi.
Thank you. So, hello everyone. I'm going to be focusing on Tanzania, and because of the context of our laws about statistics, about sharing data, I'm only going to focus to share the data from the government, the official data from the government, and then I'll be giving my overview about them. So these are the demographic from the Tanzania National Bureau of Statistics. As you can see, ours is a very young population. We are about 55.9 million people, but most of the people in Tanzania are young. The median age actually is 18 years old, so you can imagine. And these are some of the statistics that gives you an indication of why the pandemic has impacted us in a way that it has impacted us. For instance, if you look at our life expectancy, you can see that generally we don't have a lot of people who live and become like 80 years old or 90 years old. This is official statistics again from the Bureau of Statistics on the cases in Tanzania from March to May. My colleague and I, we've characterized this as the initial phase. When we're saying the initial phase, we're not talking about the waves. We're just saying the initial phase of the way Tanzania in general, and Tanzanian citizens, the government and other stakeholders proactively engaged with the pandemic. And then we have a current second phase, which is less proactive, which roughly started sometime in mid-May toward the beginning of June. So you can see on the 16th of March, that's when the first official case was reported in Tanzania, and the numbers rose very slowly, the official number, until somewhere in mid-April. That's when we started experiencing a hike, which was indicating that we were entering the exponential growth phase. And the Minister for Health actually gave a statement that now we moved from a situation where we were getting cases from outside to a situation where we were infecting each other. I'll explain later on why the cutoff point is May. So at a certain point in time, especially after the first case of death, which occurred toward the end of March, the Ministry of Health, through its unit responsible for public awareness or public education, started to share this kind of infographics on the media, which was very helpful. And I've just decided to share a couple of them for you to see how things were changing daily in April, as well as between the beginning of April and end of April. So you can see, like between the 2nd of April and the 3rd of April, the number of deaths was still the same. And at that time, you can see the government was focusing so much on contact tracing. And if you look at the difference between the contact on April 2nd and April 3rd, it's not even more than 40, which means things were still starting to come up slowly in the beginning of April, at least as far as the official data were concerned. And then when you shift again to like 3, 4, 5 days later on, you see the number of total deaths is still the same. And according to the statement of the government statement, is that it's someone who also had some underlying condition. So that was part of the discourse that was circulating at that time, that to a significant extent, a lot of people who were getting serious ill had comorbidity. And some of the numbers that were coming up in terms of age, you could see most of the people who were getting infected, they were like above 40 years old. But it was not a lot of numbers in terms of the breakdown, the gender as well as age breakdown. Like they were not like offered systematically. It was just like today we had like 5 cases in Dar es Salaam, and then they mentioned the age and the sex. And then when you go toward the middle of April and the end of April, you see the numbers going up a bit again. The cumulative death in the middle of the month was about 4, but by the end of the month, it was 16. And at that time, the government was also implementing mandatory quarantine. So then after that, we entered what we call the second phase in terms of our engagement, which, as I said earlier on, it roughly started somewhere in the middle of May, but it picked up in June, where we were having a lot of debate about how Tanzania had been handling the pandemic. So on the one hand, we had a lot of critiques. We are not very happy with the way our president handled it, especially given the fact that he didn't want to lock down. He didn't want to lock down the whole country, but he also didn't want to lock down Dar es Salaam, which was becoming the hotspot in terms of having more numbers. As you can see in this image here, like Dar es Salaam here had about 220 cases out of the 480. So for him, Dar es Salaam is like a commercial capital of Tanzania. It's a center of economic activity. And his argument was that closing down will cause a lot of economic problem. But because of that spike that was happening in April, there was a sense of panic in the social media, but also in the public. And there's a lot of criticism coming from the international media more, and a bit also in the local media. And one of the reasons why this phase also came to be is because we stopped. I mean, the government stopped giving public data. There was controversy around whether the testing kits were producing reliable results, and then a committee was formed by the minister to investigate it. And the promise was that when they are done with the investigation, they will start again issuing public data, but that never happened. And one of the rationale, at least from what we were hearing, is that a lot of information about death were causing a sense of panic, and people were getting, and there was an argument that fear was, in some cases, fear was even worse than the pandemic itself, in terms of the way people get so worried, and it then affect them. So throughout June, we were having all these major debates about what our policy really was. Was it pursuing herd immunity because of the lack of lockdown, the lack of public data about testing, and so forth. Sorry, that's my alarm for the timer stop. And then, so the debate continued. Some people started to rely on the African CDC data, but it was also very difficult to really know where they were getting their data at that time. And they also stopped at a certain point because they also didn't have up-to-date data. The last data that the Africa CDC shared was 509 cases. So all the way throughout July, this phase, which we call a complacent phase, is almost like what the president from Nicaragua was saying in terms of people being more relaxed. And a lot of critics attribute this to the president in terms of the fact that he was quoted declaring that we are now Tanzania free, Tanzania is now free from COVID. And he seemed to not really, he was not so positive in public about the use of masks. And over time, people really started becoming complacent and even relaxed, including people who were also very critical of the government in May. So it's quite surprising what happened, and probably it's because there was no longer some serious evidence of the kind of spike that we had in April. And just a couple of days back, someone from Uganda posed this question on social media, because a lot of people have been wondering what's happening in Tanzania. So after a certain point in time, people started attending soccer games, football games, soccer matches. And the red is that's Simba Sports Club, and the yellow is Yanga Sports Club. Those are like major teams in Tanzania, like Barcelona and Real Madrid in Spain. And so the question mark is like, what's happening? Have we acquired herd immunity, or is it because we're having a young population? And this became a fodder for a lot of like hypotheses, speculation, even conspiracy theory, including some of them that are coming from our leading biotechnologists and researchers, and one of them, which seems plausible, is that, and it's more or less similar like what was said in the case of Brazil, is that probably what we were experiencing was a wave, a second wave rather than the first wave, because sometime in December, there was a lot of information circulating on social media that people were feeling they were having a condition that looked like malaria, but it was not malaria. But at that time, the Ministry of Health was consulted by one of the leading social media platforms in Tanzania, and they said they were investigating, and so these are some of the hypotheses, speculation that are coming. But in the absence of data from that period and subsequent periods, it's very difficult to establish what really happened. But it's possible that there's some data maybe at the official level, and maybe after some time we may be able to know what really happened. So in terms of key interventions, they are more or less like what we've had in like in the case of Nicaragua. In my case, I divided them into four, in terms of four stakeholders: the government, companies, citizens, as well as medical health workers. And in the first phase, it was very, very proactive. There was a lot of public awareness. People were making their own masks. The government launched a health call center. It prepared some areas for in case the numbers were going to go high. People mobilized funds, both within Tanzania and the diaspora. So, because my time is very limited, I'm just going to show you a couple of pictures that just give you a feel of what was happening during this proactive phases. So that's WaterAid, an NGO in Tanzania, collaborated with the University of Dar es Salaam to come up with this equipment for people to it helps you not to touch it. Like you just use your leg, and then the water and the detergent came, and people were like washing their hands in public spaces, including bus stations. We had a lot of our scientists writing papers that seems to have policy implication. For instance, this one showed the efficacy of using homemade mask as long as you put double layers. And then there was this other one from scholars from the Muhimbili University of Health and Allied Sciences, which is located within the main hospital in Tanzania called Muhimbili. They also wrote an article which was critiquing the use of fever to screen travelers, in terms of it missing some of the symptoms. We had Muhimbili, that main hospital, becoming proactive to make PPE, personal protective equipment, and a lot of people supported it in terms of money. Like the private sector, this is PricewaterhouseCoopers, an audit agency that contributed a lot of money. We had the private sector converting some of their plant to make face mask and shield. You had UNDP collaborating with the IT digital community in Tanzania to do 3D printing, where they managed to collect 12 printers across the countries and printed about 200 units of PPEs at that time. I think the number went up later on. We had popular musicians singing about Corona. This is called Rayvanny, as you can see, has 1.9 million subscribers, and the music has been viewed by 2.6 million. We had another famous artist called Mrisho Mpoto, who also came with a song which was trying to argue that we need to, Kwaheri means bye or goodbye, but the argument of the song is that we need to make Corona go away. This is a diaspora community in the US. It managed to raise about $30,000+ US to buy PPE so that they can be distributed in Tanzania. And it also had weekly session to raise awareness about what was happening. And this is a ministry through its publicity unit, collaborating with the police and the artists I just mentioned, Mrisho Mpoto, to inform people in Dar es Salaam about washing their hands and so forth. And by sometime in April, they'd reached about 145 areas out of 218. And so briefly out of that, the lesson learned is that leaders can be role models for better or for worse. When they say don't wear masks, a lot of people end up not wearing masks. When they wear masks, people end up wearing masks at a general level. People can take positive action or become complacent, depending on many factors, including the leadership factor. Culture can be a positive or negative too during pandemics, especially when it comes to the culture of like being too close, the culture of washing your hands and so forth. And here I define culture as the way people do their things. And then religion can also help to or undermine containment efforts, even though churches and mosques were not closed in Tanzania because the president said we need them open for people to pray and so forth. But some of the churches and mosques implemented a lot of physical distancing measure within their own congregation. But we also saw cases where there were massive people congregating around the same place for religious purposes instead of doing it online, even though there are some people who did some of their services online. Information can be empowering or disempowering, especially in terms of, especially if it's used to create a lot of fear and panic, but it's also very, very important. It empowers people to know what's going on, what they should do, and this connects also to social media, which can be supportive or an anxious space. And we've seen it in both cases. There was a time people felt like it was a very toxic space. Some people had to just be away from the social media for some time. But still, on the balance of things, both social media and information, access to information, were very, very useful in the first phase, but also in the second phase. Health can be a public, private, or a personal matter. And in the case of places like Tanzania, it's really, really important for both to enhance our public health system, because at the end of the day, a lot of people depend on them, probably even more than the private sector hospital. Consideration, action taken during the first proactive phase may have helped Tanzania weather COVID-19, but again, lack of public data on COVID-19 in the current second complacent phase inhibits projections. I'm aware there are a number of researchers who are coming up with some papers and reports, so probably they might shed some more light, but currently in the public domain, it's very difficult to make any serious prediction about what will happen. But so far, things seems to be more or less better than they were in April. Both phases continue to inspire some plausible hypotheses, but they remain that speculative or conspiratorial in terms of conspiracy theories. And I'll end with this quote from Kimberly Mihayo, who works in a health agency in Tanzania, where she, in a piece she wrote, she said, in a country with no lockdowns or enforced social distancing, navigating a pandemic comes down to social responsibility. Thank you.
Thank you, Dr. Chambi, for your presentations. I also would like to thank all the presenters for sharing their presentation. We have already exceeded the time limitations for the presentation, and I guess we'll be able to address only a few questions in the discussion sessions. Fortunately, I can see only a few questions that have been directed to Nicaragua, Brazil, and India. And I see that the questions related to Nicaragua, Dr. Aurora has already responded that questions. And I'd like to pose one question to India and Brazil. One of the participants has asked that what are the most common comorbidities in COVID-19 death in India and Brazil? Maybe we could start from Dr. Zugal. Dr. Zugal, we can't hear you. Can you unmute yourself?
Okay, sorry. Yeah, this
Thank
is
you.
interesting question and very important question. Not only India, but I think throughout the world, it is well known that when respiratory diseases are there, then the COVID fatality increase manifold, and they are the COPD, which are causing problem. Chronic pulmonary lung disease or pulmonary disease, that is the one. And another one is the asthmatic and bronchitis are also another one. When you have a cardiac problem like the hypertension is emerged out to be the most problematic. But beside that, if ischemic heart disease or stroke, these people are also suffer more. Diabetes is also found to be related to increased fatality, and kidney problems, they are there. And any immunosuppressant, if person is taking in case of the cancer or related diseases, I think they are increasing their risk. So these are the main common comorbid condition which are leading to more fatality in COVID.
Thank you, Dr. Jugal. Maybe Dr. Rachel would like to add on it.
Yeah, in Brazil, I separated just the 16 or more or less than 16. The first comorbidities, heart disease, followed by diabetes. And for people higher than 16, the third is neurological diseases. And for less than 16, kidney disease are the most common comorbidities in these deaths.
Thank you, both of you. So with these questions, I would like to add another questions. We know that this COVID pandemic has put an immense strain on the health system and has disrupted the essential health services. As you already mentioned that most of the comorbidities related deaths include COPD, hypertension, diabetes, and so on. So how have the essential services been insured in your countries? So maybe,
yeah.
Go on, Dr. Jugal.
Yeah, just after the the pandemic was announced by the WHO and the government acted in India, and some cases start coming, and then a few cases in doctors and nurses were there. Immediately there was a fear, and the fear was mainly because of the pictures coming from Italy and from Wuhan, that this is killing disease, and the fatality in Italy and other places was quite high at that time. So the general services were totally shut down, and essential services were there. Essential services means casualty and emergency services were continue, and rest of the care was stalled or say withdrawn, and many of the hospitals were converted into COVID hospitals. So even the whole hospital was converted in many of the places, like in Delhi and other places, the whole hospital. Many private hospitals which were providing the general care were also converted into COVID. So no other services were given. So that was a big change, and because of that, essential services definitely suffered. When we talk about this ANC, postnatal care and antenatal care, and also the immunization, these things were also affected. And we have estimated that the vaccination is, because of that, the need of the vaccination has increased manifold, and there are children now who could have a problem if immediate some action is not taken. So I want to say this much, I think.
So any of the speaker would like to add on to
especially in the beginning of the pandemic, the epidemic, the government tried to prioritize the organization for COVID care. So we had this disruption in the follow-up of these chronic cases. So we had a reduction but it's virtual reduction of, for example, diagnosis of cancers, which probably we will have in the next years, the consequences of this. And also I would like to take attention also that Brazil suffered with epidemics, for example, of dengue and chikungunya at the same time. And now we had a problem also with measles. So also to vaccinate people, because people are too afraid to go also to the services. So they are avoiding, for example, vaccination. And also in the beginning of the epidemic, the message of the government was go to the health service only if you have severe cases or some signs of alarm. So some people were not diagnosed because they just had less severe cases, so it was they stayed at home. So we have these disruptions.
Thank you, both of you. So because of the time limitations, I would like to take only one question that has been directed to Dr. Chambi. So I'd like to request Dr. Chambi to make it very short. So the question is, how do you account for the religious belief in containing the pandemic in Tanzania?
Thank you. So as I said earlier on, religion can help positively or negatively. So in terms of positively, the major religion in Tanzania, the Abrahamic faith, basically Islam and Christianity, or their main religious book have got a lot of teaching about hygiene in terms of keeping yourself clean virtually all the time. And as I said earlier on, some of the churches and mosques, they did try to implement some of the physical distancing during their worship and so forth. But we also have so many variants or variations of belief within the same doctrines or dogma, which in a way contributed to some problems in terms of having a lot of people like congregating in the same place. But because we don't have data, because if like the church and the mosque were also giving data about what has been happening in terms of cases, it would have been helpful. For instance, in the very beginning of the pandemic in Tanzania, we lost someone in my church in Tanzania, and everybody thought it was COVID due to the symptoms that she had. So those kind of situation, if they are not captured in data, you cannot really know to what extent religion was a positive force and to what extent it was negative. But at a general level, both go. Religious leaders can support people in terms of allaying their fears. They were also instrumental in public awareness and so forth. But then you also have the other side of the story.
Okay, thank you, Dr. Chambi. Maybe that was the last questions we could discuss on. Because of the time limitations, we didn't have sufficient time for the discussion and Q&A sessions. So we sincerely apologize for taking longer time. So with this, I'd like to hand over the floor to Dr. Deepak for the rest of the information. Thank you.
Thank you, Savina, for the moderation, and thank you all of our presenters today for your excellent presentation. And not just a presentation, we had a different perspective from different presenters, and it really helped us to understand it better. And as I said earlier, this is not the end, because we want to establish a network between professionals from different countries to work together, and not just for COVID-19, but for many international health topics. And just before closing the session, I'd like to share some of the upcoming events. So as you can see in the screen, on September 30th, we have a session planned focusing on vaccines for COVID-19, updates, hopes, issues, and consideration. So among our collaborators, there are a few people focusing on immunology and vaccine development aspect, and they'll be working with other potential speakers. And so that is going to be a really interesting topic, and would like to request all of you to join this if this is something that is of your interest. And in October, November, and December, we have some other topics planned. Dates are yet to be decided, and the topics, we might change it slightly, but generally speaking, we'll be focusing on health equity aspect in October, diagnosis and treatment aspect in November, and health systems effect of COVID-19 on health system in December. Travel and COVID-19 is another topic that we are thinking to include. but these are some of the topics that we are planning for our upcoming events. Last but not least, again, on behalf of One Health Knowledge Cafe team, we'd like to thank all of you for your participation and presentation. All the PowerPoint slides and webinar recordings will be available in the Center for International Health's website, which is www.gis.lmu.de. And if you have any inquiries or suggestion, you can always email us at onehealthknowledgecafe@gmail.com. So with this, we will close today's session, and thank you very much.
Namaskar.
Namaskar.